Hello everyone, my name is Bethany Roberts. I'm going to be talking to you guys about local anesthetics, specifically pharmacodynamics, pharmacokinetics, and indications for use of local anesthetics. Starting off, local anesthetic is a drug that can provide analgesia and anesthesia for various surgical and non-surgical procedures. Local anesthetics can also be used for acute and chronic pain management, to reduce perioperative stress, and to treat dysrhythmias. We inflict perioperative stress daily, especially with our induction sequence. Just sticking a cold laryngoscope blade in someone's throat, that's simply enough to elicit a stimulatory response. So how do local anesthetics work? They produce reversible conduction blockade of impulses along central and peripheral nerve pathways, with the transmission of autonomic, somatic sensory, and somatic motor impulses being interrupted. So what exactly does any of that mean? With local anesthetics, you have a blockage of the autonomic nervous system. The autonomic nervous system includes that sympathetic response that you see with direct laryngoscopy. And that lidocaine that you administer as part of your induction sequence works to prevent that sympathetic response. Sensory anesthesia, it provides that simply in blocking sensation of pain and preventing that surgical stimulation from causing pain. And then a motor blockade occurs just through paralysis that can be inflicted with local anesthetics. With the amide linkage, you see the HNC for the amide intermediate chain. Going back here, if you look at the second structure, you have bupivacaine. You see that NHC right there for the amide intermediate chain. Just with that being said, you have all these other esters and amides if you would like to look at the structures here. Lidocaine, prilocaine, ropivacaine, all are amides and have the NH on the intermediate chain. And then you have procaine, cocaine, just a few of the esters to name that have the C and the O for that intermediate chain. Following up on that, your two basic kinds of local anesthetics, you have your amides and your esters. The amides will always have two I's in them. Lidocaine, prilocaine, bupivacaine, ropivacaine, and mupivacaine are a few of the most common. With the esters, those will only have one I in the name of the local anesthetic. So chloroprocaine, tetracaine, procaine, cocaine, one I in all of those. Moving along to pharmacokinetics, by nature, local anesthetics are weak bases with pKa values above physiologic pH. Which environments are local anesthetics going to work poorly in? And the answer to that is going to be a acidic environment. So an area in the body where there might be an infection, you wouldn't want to go and try to inject local anesthetic. More than likely, it's not going to work very well due to that local anesthetic being a weak base. Local anesthetics with pKa's closest to physiologic pH have the most rapid onset, and that's due to an optimal ratio of ionized to unionized drug fraction. If you'll remember back to early on in pharmacology and in chemistry, it's the unionized portion of the drug that is the active form. So the more unionized drug that you have, the more of a response that you will tend to see. Local anesthetics exhibit uptake via its vasodilation. Uptake in particular depends on three things. Those three things include vascularity at the site of injection, the dose, and the inclusion of a vasoconstrictor. Adding a vasoconstrictor is essentially going to prolong the duration of action due to the decreased uptake that occurs with vasoconstriction. So if you add epi to your local anesthetic, you're obviously going to see a prolonged block because those vessels in that area are going to vasoconstrict and there's going to be less uptake of the drug from the site. Esters in nature are very potent vasodilators. kind of the breakdown for that. So you have vasodilation. Following vasodilation, you have increased vascular absorption. Then that's going to lead to decreased duration and increased anesthetic blood concentration. This is where you can get your possible toxicity of your local anesthetic. Cocaine is the only vasoconstricting local anesthetic. As I mentioned, uptake depends a lot on the vascularity. With that being said, the higher the vascularity of an area, the higher the risk of toxicity. So a fun little acronym I found to help you kind of remember the order of vascularity is biceps. The blood is obviously the most vascular area where you can put local anesthetics, so that is obviously the first one, followed by intercostal, then by caudal. The E then stands for epidural, the B for brachial plexus, and the S for sciatic, and you have biceps. Once the local anesthetic is in the blood, it is distributed to all tissues. The vessel-rich organs receive high levels due to high perfusion. Metabolism of amides occurs through the liver via microsomal enzymes. This is the whole CYP450 system. It's really important to proceed with caution in administering these to patients with liver disease or people that have poor hepatic blood flow. They're not going to metabolize these drugs as quickly. There's going to be more lingering around, further producing an increased risk of toxicity. Metabolism byproducts of amides can possess clinical activity as well. So, especially if these patients have significant liver disease, it's important to proceed with caution or decrease the dose that you're administering. Metabolism of esters. Esters are hydrolyzed in the plasma by pseudocholinesterase. The only one that is not is cocaine, and that's metabolized in the liver. After metabolism of esters, the byproduct is PABA, is the little acronym. PABA stands for para-amino-benzoic acid, and this has been associated with allergic reactions previously. And PABA is a chemical that's found in vitamin folic acid. It's also been found in some grains, eggs, milk, and some different meats. It's also commonly present in medicines for autoimmune diseases. Another point to note is that all classes of local anesthetics can have a preservative known as methylparaben. That resembles PABA and can cause a reaction. A lot of the local anesthetics on the market today are preservative free, but it's always something important to pay attention to and to take notice of. Back to the metabolism of esters. After the metabolism, the byproduct of esters is PABA. We noted that already. Adverse reactions can occur with patients that have abnormal pseudocholinesterase function. These are your patients that maybe have had succinylcholine in the past and have had a prolonged neuromuscular block. Kind of look into their history, see if there's been anything strange like that in the past. These patients would obviously have a prolonged block if they were to receive ester local anesthetics. Another fact that I think is worth mentioning is that lidocaine, bupivacaine, and prilocaine, all which are amides, are capable of extracting local anesthetics by way of pulmonary first pass through the lungs. This, along with its rate of metabolism, can definitely influence toxicity. Esters produce less toxicity in regard to its rapid hydrolysis. Basically, it doesn't allow substantial amounts of local anesthetics to linger around just because it's hydrolyzed so quickly. Excretion of all local anesthetics is through the kidneys. Esters are excreted through the kidneys as well. It's just in much smaller amounts, primarily because they're almost completely removed through hydrolysis. Once the local anesthetic is in the blood, it is distributed to all tissues. The excretion of all local anesthetics is through the kidneys. Esters are excreted through the kidneys as well. It's just in much smaller amounts, primarily because they're almost completely removed through hydrolysis. Local anesthetics and pharmacodynamics. So locals bind selectively to sodium channels in the inactivated closed state and stabilize the channel in the inactivated state. So what you have happen is with your action potentials, the local anesthetic, as you see in that third portion of the picture, the local anesthetic is going to block that sodium channel. Therefore, there's no sodium influx into the cell. Threshold potential is never reached, and the action potential does not occur. This is going to be prolonging your depolarization phase, and you're going to get a sodium channel block per se, which is what lidocaine is noted as with its antiarrhythmic effects, class B antiarrhythmic. Systemic toxicity. Another really important point to note, intravascular injection is one way that this can occur. It's the most common way that this can occur. Another way is through increased plasma concentrations following absorption. Biceps, if you go back to that acronym, high flow, high absorption, high chance of toxicity. It's important to know the dose ranges for each local anesthetic with and without epi before administering. Find little acronyms, little ways to remember each one. It will definitely help you in the clinical arena. Symptoms of local anesthetic toxicity can include circumoral numbness, facial tingling, restlessness, vertigo, tinnitus, slurred speech, leading to tonic-clonic seizures, respiratory, and finally cardiovascular arrest. The seizures that you can see are thought to occur due to selective depression of cortical inhibitory neurons. And what this means is essentially it's blocking the inhibitory neurons, leaving the excitatory pathways open. And this allows for seizures to occur. As you know, seizures are excitatory actions. Larger doses may eventually block both excitatory and inhibitory pathways. And this is going to further lead to your cardiovascular collapse. And your cardiovascular collapse is due to the blockage of cardiac sodium ion channels. And what you're going to see with cardiovascular collapse might start off as prolonged PR interval and widening of the QRS. If you have epinephrine in your local anesthetic, you'll obviously see changes in your heart rate. Tachycardia might be one thing you see. Local anesthetics toxicity can be treated with 20% intralipids IV. The dose is 1.5 mils per kg. It's not completely understood, but it's believed to be related to its ability to extract that lipophilic drug from the aqueous plasma or tissue targets, essentially decreasing the concentration of local anesthetics. I wanted to put together just a few fun little facts about local anesthetics. It's kind of hard to condense so much information into this little PowerPoint, but these are a few things that I feel like are still important, although are not necessarily coined under pharmacodynamics and pharmacokinetics. But cardiotoxicity is obviously a really huge thing to take caution of with using IV bupivacaine. And the reason that it's expected to occur is due to slow dissociation from cardiac sodium channels. Lidocaine, which is also another amide, local anesthetic, enters and leaves the channel quickly. It doesn't exclude it from being cardiac toxicity. However, bupivacaine is far more potent and prone to depressing the maximum upstroke of the cardiac action potential in that ventricular cardiac muscle. And this coins it the fast in, slow out local anesthetic. Basically meaning it might set up real fast, but it's going to hang around for quite a while. Placental transfer is another thing that I want to talk about briefly. So, placental transfer rarely occurs with ester local anesthetics, and that's due to its rapid hydrolysis. However, with amides, accumulation of local anesthetic can occur in the fetus due to ion trapping. And this is primarily due to the pH differences between mother and the fetus, as well as protein binding. So, obviously, the mother is going to have a more alkaline in respect to the fetal pH. So, your fetal pH is definitely going to be more acidic, therefore trapping those amide local anesthetics. Chloroprocaine is a popular short-acting ester. It's known to decrease efficacy of subsequent local anesthetics due to tachyphylaxis. Boricity, another important point to note. Boricity is the density of local anesthetics. So, naturally, the cerebral spinal fluid specific gravity is 1.000 to 1.003. Less than 1.000, you're going to have a hypobaric solution. This can be made adding water to a local anesthetic. With hypobaric solutions, the local anesthetic is going to float cephalad, so closer to the head. So hyperbaric solutions, on the other hand, are going to have dextrose added to them. These are solutions that have a specific gravity greater than 1.003. Therefore, local anesthetic is going to go caudal and further towards the feet. Hyperbaric bupivacaine is what we commonly use with spinals. You'll notice that patients are laid down quickly following an administration of hyperbaric bupivacaine, and essentially boricity is kind of one of the reasons why the whole spread thing is set to work up. And guys, that's really all I have for you today. I know it's kind of a lot in a little segment. If you have any questions or anything that you want to add in or that I messed up on, feel free to comment and let me know. Thanks.